What I want you to see is we don't have to write a ton because my communication is in the provisional. For copying what I worked out in the mouth. Fun stuff. Fun stuff. All right, let's spend a little time on vertical. And we're going to talk about this from a philosophical standpoint first. And the first thing is I do think Dr. Dawson's chapter on vertical dimension may be the best ever written. And I'll tell you a little bit about what he believes about vertical. And then I also want to present it from the other side because there's another side that believes something different. He believes that the repetitive contracted length of the muscle sort of sets vertical dimension up, and if you mess with it, it's going to go back, right? And patients might not really understand or notice that at all, but that muscle sets up the dimension. And there's other people that say that when we open vertical dimension, the muscles adapt, which is true. We don't 100% know. There is some good science supporting Dr. Dawson, but my point to you is it doesn't really matter because both philosophies say we can open vertical dimension and nobody gets COVID or dies or any of that stuff, right? So don't be afraid of changing vertical. If we need to change vertical, we can do it. But let's look at what Pete said first. The first thing to remember is we actually measure vertical dimension in maximum intercostation. Right? So there's two places we can measure vertical dimension, kind of from the nose to the chin, as the teeth are in occlusion in MI. And then in that position, I want you to also think about that there's a length of muscle in the master, medial pterygoid, and temporalis. Pete believes, or believed and taught, that when we swallow 3,000 to 4,000 times a day, and our teeth lightly touch, there is a repetitive contracted length of our closure muscles that sets up that dimension, and that distance between the nose and the chin is based on that repetitive contracted length. So again, muscles are there before teeth. That dimension between the nose and the face is dictated by that muscle length, that repetitive contracted length, and then teeth basically erupt until they meet an equal and opposite force, erupting within that space, and that's what sets up the vertical dimension of occlusion. Based on muscle, creating that dimension between the nose and the chin. Now he goes on to say, and this is work by McAndrews, who is an orthodontist in Alabama, that back when we could take serial septs on patients, there's a lot of radiation, but he showed ortho cases where he would open or close the vertical dimension as much as 7 millimeters orthodontically, and when he would come back 7 months later and measure, the distance between the nose and the chin would be back. So if we open vertical dimension or close vertical dimension, the dimension would go back, not by intrusion, but by virtue of the fact that the whole alveolus would adapt. It would go back. Right? So what I want you to think about this is, if that's true, patients, when we change vertical dimension, either orthodontically or prosthodontically, if we make their occlusion good all the way around, this adaptation will occur. The patient will not even know it's happening. They don't have pain, they don't have discomfort, there's just adaptation. If we try to open the vertical dimension just partially, or we do it with bad occlusion, they have trouble. Right? So the requirements of occlusion is really critical when we start changing vertical dimension. Now the other thing we got to be careful of is that we're talking about teeth. And when we're changing vertical dimension on implants, implants don't adapt. And so in my world, when I see a really closed down bite and we need space, I'm much more likely to try to get my space through tabling a bone rather than opening a bone. Because if we open the patient up on implants on the wrong person, they may get back to the original vertical dimension at the expense of our dentistry. joints, implant failure, right? Broken screws, or all those fun things, right? That make those cases so fun. So I'm more apt to be more picky about maintaining the vertical dimension, be really careful about it when I'm doing implant cases. So just a couple things. The repetitive contracted length of the muscles determine the mandible to maxilla relationship to which teeth erupt. Teeth erupt until something stops them, which is usually the opposing tooth. Also could be a tongue, right? If you have a tongue thrust, that can go in there and stop the eruption. Teeth and muscle war, the muscle never loses. And so that's why when we open a bite and we started infringing upon the repetitive contracted length of muscle, we'll have intrusion. There's other things that we see in dentistry. It's not as common anymore, but there used to be, down our way, a dentist that would make these segmental gelb appliances. They were like posterior TMJ appliances where they didn't touch the front. And they would put them in and adjust the occlusion, but the front teeth would be open. And within about 6 months, you would see when you took the appliance out, none of the back teeth touched and the front teeth touched. Now there was some eruption of the front teeth, but there was also a step occlusion by intrusion of the back teeth. The other thing that he believed and taught was that even in rapid abrasive wear, if you start pay attention to the CEJs here, if you've got somebody who starts like this and wears their teeth down and they get really small and short, these people aren't losing as much vertical dimension as we think, right? Because as teeth erupt, they allow the alveolar processes elongate. And again, if you doubt that, look at your next wear case and try to plan where the incisal edge is. And they could be 5 millimeters long. And if this isn't happening, you should be able to add 11 millimeters to the incisal edge. And that's not happening because they're elongated. You see these long alveolar processes. So the key point is even in rapid abrasive wear, this does not result in a loss of vertical. Now, the key is I'm not saying we can't open vertical on these cases, because we can if we do, but we're not restoring vertical. We're changing vertical, and all I'm saying is when we do that, we do create a little bit of potential instability in the system while things adapt. So depending on the case, I may keep people in provisionals longer. It takes about 6 months for the adaptation to occur. Depending on how much I'm opening and what's going on, it may be something I have to consider. The other thing that's great about these cases is they almost always need crown lengthening. So if I get the temps in and they're healing from the crown lengthening, I can kind of let that help the time too. It's another reason why I like getting a temp solution. The other way to look at this is if you look at some hard numbers, kind of zygoma to the cusp tip of a second molar, and from the bottom of the mandible to the cusp tip of the mandibular molar. And then you look at the A line, which is from the zygoma to the pregingival margin, and from the angle of the jaw to the pregingival margin. When people wear out, what we see is B does not change, but A changes a lot. So as we're wearing, this part is elongating, right? As the tooth gets shorter, it's elongated. Now what causes the class 3 is they get kind of edge to edge. You know, is it overclosure? I really think a lot of it comes from the fact, and I said it with Brian this morning, is as they're losing and wearing up the linguals of the upper, the pressures from the lips brings them back. So you might get a little bit of closure, but a lot of it is neutral zone. So when we open the video, we will often create some instability while the patient physiologically adapts. It generally takes about 6 months for this to occur. If the occlusion is good, the patient won't even be aware it's happening. All right, so when we do this. But there is one important exception to understand that really helps us, okay, and it has to do with centric relation. A lot of these patients, when we look at them, we're talking about vertical dimension in maxillary intercuspation. And what I want you to pay attention to is the muscle length in maximum cuspation. If this patient's condyle is down and forward, when we put the patient in centered relation, the posterior slides up and back as we get open in the front and hit an interference back there. And as we slide in this direction, muscle length really doesn't change. So what I'm saying is, when I see wear and tear, I'm praying for interference in the back that gives me space. Because if we shift in this direction, we have all this space where we can work where we have not affected muscle length. So when we have these CRMI shifts where I can add to teeth, like I did with Brian, we're not going to have to worry about the compensatory adaptation that occurs afterwards. Now, you're going to run into people that have just worn themselves right into centered relation. That's a true, muscle link change. But when you see this shift, that helps us tremendously. So condyle position affects vertical dimension. The muscle length between here and here hasn't changed, but this gives me a lot of work to deal with. So we've seen this one a couple hundred times, but if, for instance, we don't need to, but when we look at Chrissy and we look at her at the first point of contact in centered relation, the muscle length from MI to this is the same. And if I wanted to add to those teeth, I could do it safely and we wouldn't have any issue with that at all, okay? So when we have posterior interference of centered relation, we want to open the VDO. It gives us the space to add to the teeth without affecting muscle length, and that adds tremendous predictability to what we're doing. Now, other papers that confirm the safety of altering VDO. Basically, in this review, we have concluded that a permanent increase in VDO once indicated is a safe procedure for dentulous patients. However, it is important to minimize the extent of the increase to simplify the prosthodontic treatment process. An interincisal increase exceeding 5 millimeters is seldom needed. I could not agree more. Most of the time, it's less than 3. Moreover, it's important to consider the functional, aesthetic, and biologic elements associated. Muscle relaxation and changes to muscle length are likely the primary adaptation mechanics rather than the restoration of the original VDO through dental alveolar maturation. So that's the other viewpoint. Point is, they both say it's safe. Okay, both say it's safe, so don't worry about it. As I will go through these cases with you, just understand that VDO is something that I absolutely consider, and there's certain cases that you cannot fix the situation without alteration. And Brian is one of them, and we'll look at some others now. While there's debate about what actually happens when we open the VDO, there's little debate that it is a necessary, predictable protocol when executed properly. The most important thing, open it all the way around and optimize the occlusion when you do it. So you can't just I have dentists that want to open the vertical and they go, well, I'm just going to open the back first. You got to open it all the way around. That's why when you think of Brian's cases, I did it with toppers and bonding, but we created an ideal occlusion. That's what we have to focus. Ma'am.
Do you find that after, say, the 6 months, for instance,